Before we start, I would like to request the presenter to confirm that they are ratified members of AIOS. The presentation will be 6 minutes and 2 minutes for the question and answer.
Glaucoma 2 score sheets.
What the?
Where is the mark sheet?
Yeah. एक और दे दीजिए ना वो आलो mark sheet. This is session 1. This is not ours. This is session 1.
This is glaucoma 2.
Give me session 2.
This is glaucoma 2.
No, I don't have. Yeah. This is 2.
चलो, announce करो.
राजुल के नाम से. पिलू ऑन करो पहले.
So, the first speaker is Dr. Rajesh Joshi. Please.
Good morning, everyone. Respected judges, I will be presenting this paper on translid tonometry. This was developed in conjunction with VNIT Nagpur. There are various methods for the measurement of intraocular pressure. Out of this, applanation tonometry by handheld or slit lamp is the gold standard method. There are various drawbacks of various methods which are available for the measurement of IOP. Direct contact with the cornea and the cost which is involved and the physician need. This is in line with to encourage Make in India products. The objective of the study was to develop device for translid tonometry and its feasibility for the measurement of intraocular pressure in the normal and glaucomatous individual, and a self-measurement of IOP if at all it is possible in glaucomatous eyes at home. The working principle of is this indentation and applanation as well. When the pressure is applied on a sphere with a force F, causing the displacement in the sphere, the pressure inside the sphere is equivalent to force upon the area which is applied. So which is the invert flux principle which is applied in this device. This was the experimental device which was developed. The cylinder has a plunger and a pressure sensor. The plunger has a circular plate which is of the size of 3.06 mm. The tip of the plunger was placed over the closed lid and the plunger applanates the cornea. The pressure exerted is transferred through the pressure sensor to the control unit which is here, and the designated circuit will convert the resistance which is placed on the lid into the signal, either red or green. So this was the instrument which was done at VNIT. But the initial device which was developed was cumbersome with lot of wires, and it was heavy also, and it was indicating just red or green signals only. There was lack of digital reading. So the finite element model was created in the laboratory, and this model was devised to measure the pressure in the laboratory. This was the indenter, soft indenter which was devised, and this was various finite elements which was used to construct the eyeball. The prototype of this device you can see on your right. It has a plunger, spring, and the applanating device which was placed on the lid. But the concern was how the lid pressure was taken into consideration. The pressure exerted on the cornea by the eyelid is equivalent to 4.1 mm of mercury by the area of contact of 3.01 mm. This is equivalent pressure needed to flatten the cornea over the eyelid is equivalent to IOP minus eyelid pressure. So force needed to flatten the cornea over the eyelid is equivalent to applied pressure upon the area of contact. So this curve was devised. Once you apply the pressure, more pressure is applied, the pressure rises. The initial device was bigger size and it was indicating on the monitor how much pressure is there, but it was on the bigger side, so we unable to see what exactly it flattens. It was reduced to a small design which has high sensitive pressure transducer. Initial pilot study was devised with Schwartz tonometry, but the main aim was to compare with applanation tonometry, and this shows the mean pressure in both the groups, but the pressure which is seen by new device was higher as compared to the Schwartz tonometry. So this was done at a tertiary eye care center prospective observational study. A single observer took pressure by new device and applanation tonometry, and the assignment was consecutive and the data was compiled on the sheet. The video shows where you need to press with the device. You can see the elevated area here, and once the patient closes the lid, the area which is there is around 4 mm above the upper eyelid. And this shows the device which is there, the 2 mm of the plunger which presses on the closed eyelid, and once it gets pressed, it shows on the monitor how much pressure is there inside the eye. The cleaning of the device you can carry out with the help of distilled water or with the help of saline. As it doesn't touch the cornea, it will not cause any corneal infection, or you can do with 0.5%, 0.05% sodium hypochlorite solution. These were the statistical methods which were applied to compare the difference between the two devices. The total eyes which were studied were 200. The mean age, you can see the demographic profile, and there wasn't any difference between the applanation and the new device as well as consecutive eyes were concerned. This shows the coefficient of correlation and regression analysis in both the groups, and they were fairly correlating. You can see once the pressure with the help of the applanation and the new device, it was correlating very well. The sensitivity and specificity of the device was also carried out. The sensitivity of the device was 90%, shows that it is able to detect positive glaucoma subjects 90% accurately out of all subjects. The specificity was 88%. This device can detect negative cases up to 88%. The advantage of the device is portable, simple for health workers in rural area, a simple method to measure IOP. No need of ophthalmologist if the patient wants to measure IOP at home, but this needs to be studied in large group. Screening of the patient in camp and rural areas. The limitation of the device is we are in process of fitting camera to this device, which will the observer will come to know where it is exactly pressing. Multi-center studies is needed. The conclusion from the study is that it is equivalent to the applanation tonometry. The scatter plot indicates the excellent correlation between the new device and applanation. The device allows for accurately measuring the intraocular pressure through the eyelid without touching the cornea. Zero contact with the cornea or influence with the corneal biomechanics results in the rapid screening of the device. This is the acknowledgement, and thanks for your patience listening.
So,
Any question?
so the first you measured with the applanation and the new device.
Yeah, new device.
Whether the testing of the sequence was the random or it was fixed. That first applanation and then new device.
It was fixed, like first applanation and then go for new device. Yeah.
Why?
Well, because we thought there was in fact
and
no
what
reason
was,
for there
what
was
what was the time gap between the two?
We kept a time limit of around 5 to 10 minutes in between the new device and the applanation one, so that the effect of anesthetic agent which is there, which will get negated in 5 minutes or so.
So why it was not random?
It was consecutive allotment and there was no randomization done in fact.
No, randomization not, you done, there is no randomization. I am just talking about the pattern. The testing should have been random. So some patient should have got the new device IOP measurement first and then applanation, and some other way around to reduce the bias. When you do check the consecutively one applanation and second new device or vice versa, there is always a chance of bias. So
We
that
thought
should have
of,
been no, that should have been taken
yeah,
care of.
okay.
So I am not asking you, I am just telling you this is not correct.
Okay.
When you design a study, there are certain things which you have to look into it, so this is not the correct way of doing it.
Okay.
And then second thing, the predictive values cannot be calculated from the sample. It should be calculated based on the disease prevalence. So if you calculate from your only study population, it is always going to be skewed on the higher side. So that is not the way you calculate the predictive values. Okay?
And personally, like Rajul said, even I felt that your new device pressure should have been recorded before installation of an anesthetic and then doing the applanation.
Okay.
Like both ways would have been better. And was there any exclusion criteria, condition of the lid or random at 4.1 adjustment was done for all recordings?
No, in fact, there was no exclusion criteria. Consecutively, the patients were included in the study.
Okay. Any lid abnormalities were taken into consideration?
Yeah, that might affect, but
That will certainly affect the readings. Thank you.
Now we have second presentation on evaluating a new visual field strategy to confirm early optic disc changes. Are you a ratified member?
The non-ratified member, so we don't have to.
A very good morning to one and all. Today I'll be presenting our findings on evaluating a new visual field strategy in relation to early optic disc changes. So as we know, static perimetry is the gold standard of monitoring progression in glaucoma, and the Humphrey Visual Field Analyzer 2 has full threshold fastback, CETA standard and CETA fast algorithms. CETA standard and CETA fast were introduced with the aim of reducing test duration by 50% from the full threshold and fastback strategies respectively. In the Humphrey Visual Field Analyzer 3, we have the CETA faster strategy, which further reduces test duration by 50% from CETA standard. The current recommendations are to perform 3 perimetries for the first 2 years of diagnosis. And studies have also shown that testing the central visual field is sometimes useful in early glaucoma too. CETA faster is a strategy that incorporates 10 asymmetrically distributed test points from the 10-2 grid onto the 24-2 grid. The purpose of this study was to study the correlation of 24-2C CETA faster strategy results with the optic nerve head changes. It was a cross-sectional study conducted in a tertiary eye care center in Eastern India from June 2021 to October 2021. We included patients of 18 years of age or over who were either untreated disc suspects or untreated cases of raised intraocular pressure. Patients with suspected or already diagnosed neurological problems were excluded from the study. At the first visit, IOP was measured by Goldman applanation tonometry, and patient was examined on the slit lamp with a 90 diopter Vogue lens for any presence of optic nerve head changes. Patients with any detected changes or a raised IOP were then subjected to stereophotography for obtaining image of the optic nerve head, and then visual field was done by Humphrey Visual Field Analyzer 3 in CETA faster strategy. In this image, we can see the central test points from the 10-2 grid on the 24-2 grid. And the right eye shows a few central as well as peripheral scotoma in early optic nerve head change. Statistical analysis, descriptive statistics were used, and Pearson's correlation coefficient was used to study the correlation between continuous and quantitative variables. 50 eyes of 28 patients were studied who had optic nerve head changes or raised IOP. The mean age was 44.5 years, and we did not obtain any significant correlation between any of the reliability indices or other values on the visual field report with the optic nerve head changes. The mean cup to disc ratio was 0.52, mean intraocular pressure was 19.48, However, the presence of dense scotoma in the visual field report correlated positively with presence of increased cup to disc ratio. A maximum of patients we studied had a normal or increased cup to disc ratio, with a minority also having some neuroretinal rim abnormalities. We did not study the correlation of false negatives with optic nerve head changes because there is existing evidence to suggest that false negatives do have a positive correlation with presence of glaucoma. The other reliability indices did not have any significant correlation. Majority of the eyes with optic nerve head changes had peripheral scotomata. Hence, the CETA faster may be preferred to the 10-2 grid in early glaucoma. In diagnosed cases of early glaucoma, it can be used to monitor central involvement. In advanced glaucoma, it may be used to monitor both central and peripheral involvement simultaneously due to lack of time. Mean test duration we obtained was 178 seconds, which is comparable with other studies which obtained Hale et al. Obtained 170 seconds with CETA faster, and both these are much lesser compared to the test duration of CETA standard. The limitations of our study were a small sample size, absence of follow-up, and lack of comparison with other field strategies. In future, this can be compensated for by comparative studies and correlation with optical coherence tomography findings. To conclude, with an increasing disease burden, the recommended frequency of follow-up and perimetry, the CETA faster strategy may be a time-efficient way to monitor progression of in peripheral visual field as well as detect early involvement of central visual field in glaucoma. Thank you.
Have you repeated the fields again to establish two good baseline?
Yes, ma'am. That was one of our limitations, that we did not.
And that
repeat
is
the
not been
fields.
done.
Yes, ma'am.
So, first question, whether these patients were perimetrically trained or novice?
They were not perimetrically trained, sir. They were all patients who visited the clinic. Most of them were having a perimetry done for the
You
first
don't have
time.
data that how many were trained and how many were doing first time.
No, sir. But there were very few people who had any previous experience of perimetry.
Second, from your data, the conclusion, other than time, your data does not tell anything. So your conclusion should be based that only that it is time saving.
Yes.
Because you are not compared with the standard care that is 24 days 2 or some people do 30 days 2 plus 10 days 2 when you are combining. Then you can say that it is matching up and maybe it's better to do. So your data was very limited and your conclusions way beyond your what data is showing, because your data is not showing anything. Okay, because you are not compared with the standard perimetry. The disc evaluation, how it was done, you are not mentioned. Who did the disc evaluation? I know you saw stereophotography, but who evaluated? Whether they were glaucoma specialists with how much experience. The patients were doing first time field, then there can be a learning effect. Though it can be within the false positive and false negative fixation loss can be within acceptable range, still the patient have a learning error. Okay, so whether if the first fields were not excluded, those all will come as limitation of the study. So the conclusion should be based only on data. Your conclusion goes far beyond what data is actually telling. Okay.
The next presentation is on conjunctival inflammatory markers in primary open-angle glaucoma and primary angle closure.
Thank you. I'll be talking on the conjunctival inflammatory markers in POAG vis-a-vis PSCG. We have no financial disclosures. What was known previously is that conjunctival inflammation, both clinical and subclinical, recruits fibroblasts, and which is a risk factor for scarring in trabeculectomy. And that concept of treatment naive and vis-a-vis conjunctival treated with AGMs came into being from the early 1980s. What was also known, what the cells identified were mast cells, HLA-DR, goblet cells, neutrophils, lymphocytes, and macrophages. However, there was no Indian study, and knowing that our ethnicity is different and the propensity for fibrosis is more in pigmented races, we aim to identify and compare conjunctival cellular and inflammatory profile in POAG and PACG patients scheduled to undergo trabeculectomy. It is a prospective, comparative, interventional, exploratory study. Because of COVID, our sample size was reduced almost 1/3 because this study was designed in 2021. And it was an uncontrolled primary ACG and OAG requiring trabeculectomy with age more than 18 years were included. Prior incisional surgery involving conjunctiva, dry eyes, long-term topical steroid use, chronic ocular pathology like keratitis, uveitis, episcleritis, and scleritis were excluded. Material methods, trabeculectomy with releasable sutures, mitomycin 0.02% for 2 minutes was only given in patients with less than 50 years, with conjunctival frill incision technique popularized by our center was done. Conjunctival tissue biopsy it was all cases was inferotemporal. It was subsequently fixed with formalin, paraffin embedded sections of 30 trabeculectomy eyes, 15 PACG and 15 POAG were taken, and cellular profile and immunology histopathology was done by 5-micron sections. These are some of the pictures of the staining of hematoxylin, eosin, pars, diastase, and Masson trichrome. Electron microscopy was done for labeled immunocompetent cells profiling in conjunctival stroma. 4 different fields were averaged. Immunohistochemical markers which we did were T lymphocytes CD3, B lymphocytes CD20, macrophages CD68 markers were taken. Control samples were only 5 age-matched cases of cataract surgery. Outcome studies were the comparison of conjunctival inflammation and pattern of POAG vis-a-vis PACG vis-a-vis controls, and inflammatory cells, fibroblasts, goblet cells, and then their correlation with preoperative IOP and the number of anti-glaucoma medications. What we found was that the conjunctival inflammation was pre-existing in 13% cases as mild and intense in 40% cases. No inflammation was seen in 46%, and it was virtually similar for both POAG and PACG. Inflammation was primarily superficial and the pattern was primarily patchy. This is the stains showing the dense inflammatory exudates, dense inflammatory in the conjunctival biopsy sample. In the left side is for the patient, and that's a control group of the cataract patient. While comparing fibrosis, again, there was no fibrosis in 73%, and pre-existing fibrosis was there in 1/4 patients approximately, it's 26-27% patients, and it was virtually similar for both POAG and PACG, and there was no statistical significance by Fisher's test. The cell pattern was again inflammatory and fibroblastic, with the fibroblastic being more common. Inflammatory cells comparison was that the CD3 was more CD20 plus B lymphocytes was significantly, not significantly, actually didn't attain significance, was more in the PACG vis-a-vis POAG, and the macrophages was more in the POAG vis-a-vis PACG. However, none of these turned significance. We did both the medians and the mean because our sample size as for necessity was less. So these are some of the pictures of the immunochemistry markers and cellular profiles. In addition to increased B lymphocytes, fibroblasts also increased in PACG. Goblet cell comparison loss was much more in PACG, but the difference again did not retain significance. Preoperative IOP was correlated, and the CD68, which were macrophages, which were increased in POAG, had a negative correlation trend only with the IOP. Fibroblasts, which were increased in PACG, had a positive correlation with IOP. Pre-op IOP was similar almost for both the patients, at POAG being 40 and PACG being 35 mean. Correlation of conjunctivals with the AGMs, again, the POAG group, the goblet cells had a negative correlation with AGM, and fibroblasts a positive correlation. For the PACG, T cells had a positive correlation with AGMs. So what did we learn? Pre-existing inflammation was present in 53% patients, intense in 40%, fibrosis was seen in 1/4 patient, cell pattern was fibroblastic primarily, goblet cells were 3 times less in PACG vis-a-vis POAG, inflammatory cell increase was there, CD3 was similar in POAG and PACG, B lymphocytes were much more in PACG, and macrophages were 1.5 times more in open angle. So we didn't reach any conclusion as is with this, there was just a trend. Increased in AGM did give rise to decreased goblet cells, increased fibroblasts, and increased T cells. Inflammation was primarily superficial, pavot distribution being patchy. Fibroblast had a positive correlation to preoperative IOP in the POAG group only. Limitations of a study, duration of AGM use was not there because it had given more realistic information on content profile, but the patients of ours had an issue of adherence and did not know. So we recommend that link with long-term bleb survival and identify the key inflammatory cell may be the key to bleb survival. Thank you.
Next paper.
Questions?
So only one, of course, as you mentioned, sample size was
Yeah.
small, we should have larger number.
Actually,
But
we
you
had
had-
planned more than 60, but we became a COVID
think you can-
hospital. We
you
became a COVID hospital.
You can
so we're-
continue now once
I
COVID is
will,
gone.
yeah.
But the only thing when I saw the number of AGM
Ah.
was the more than 3, 4 was,
Mostly there were two. The mean
no, one I saw the slide, that the number 4 or more medications, POAG was 1 and PSAG was 4.
Yeah, but the,
So
again,
if you exclude that group,
the-
whether they had any impact, of course the number small sample will become more smaller, but whether it had any impact on the results.
No, actually, these were just 1 or 2 each, which were on 4, because these patients, the problem with our patient profile is that most of these patients depend on the hospital for their,
Then
supply. So, to correlate was little dicey because how many times they were actually using it in that 2
So-
years or 1 year. But the ones which were on 3 or 4 AGM, if we exclude them because thinking that they would be affecting more of on the fibrosis or the inflammatory cells, we could do that. We could do that if we have a substantive amount in
Ideally,
each
we should,
set.
I think, wash out and do surgery after 3 to 4 weeks. That would be the
again,
remove the
ethical,
drug.
again, the ethical clearance
So,
cannot be made because of high pressures to wash and give Dimox
Dimox.
for
Yes, yes.
3
With
weeks.
acetazolamide.
It ethically cannot be done.
I don't think that would be a big issue. If EMGT can do without medication, glaucoma patient, non-glaucoma, I think it's definitely maybe difficult to convince, but not impossible because we are not ethically wrong. If you really want to know the
Because
impact of
washout would be at least 1 month.
3 weeks, yes,
At least 1 month, 3 weeks
yes,
to 4
agree.
weeks. So that
Yes.
way.
Yeah, thanks.
Any other? Thank you.
The next speaker is going to speak on correlation of blood parameters as a novel biomarkers in POAG case. Deepak Mishra. He talked to me. He has some presentation in other hall also. So we will take him if he comes in the end, okay? So the next speaker is 1 year outcome of trabeculectomy surgery in open angle glaucoma.
No, one report.
Sorry. An OCT, a study of microvascular alteration in glaucomatous and diabetic eyes and their association. Madam, are you a ratified member?
Yes, ma'am. Hello. Good morning to one and all present here. My talk for today is on the topic an OCT angiography study of microvascular alterations in glaucomatous and diabetic eyes. I have nil financial interest. So as we all know, OCT angiography is a novel technique introduced in 2006 which allowed non-invasive visualization of the microvasculature of retina. It's proved to be useful in glaucoma for quantitative assessment of vessel density, capillary perfusion percentage, and flux index. It detects microvascular changes in the superficial and deep vascular layers of retina. Our purpose was to analyze and compare the peripapillary microvascular alterations in glaucomatous eyes in patients with and without diabetes and age-matched healthy eyes using OCT angiography. It was a case-controlled study which was done in age-matched individuals of 40 to 60 years. And the duration was for 6 months. And OCT imaging was done of the optic nerve head, retinal nerve fiber layer, and fovea. And OCT-A imaging was done of the peripapillary and foveal region. The scan size of 4.5 into 4.5 mm was taken for the peripapillary area, and the scan size of 6 into 6 mm was taken for the foveal area. Our primary objective was to analyze capillary perfusion percentage and flux index at peripapillary area in glaucomatous eyes with and without diabetes versus age-matched controls. Secondary objectives were to analyze alterations in vessel density at fovea and also to establish relation between diabetes-induced retinal microvascular changes and severity of glaucoma. The participants were broadly divided into cases and controls, cases being participants with glaucoma, further subdivided into without diabetes group and with diabetes group, and controls were participants without glaucoma, further subdivided into without diabetes and with diabetes group. The inclusion criteria was 40 to 60 years of age, normal anterior chamber depth and open angles, best corrected visual acuity of 6 by 12 or better, and no history of intraocular surgery except cataract in the after first post-operative month. Exclusion criteria were patients with any media opacity including corneal opacity and cataract greater than grade 3, any retinal or macular pathology including diabetic retinopathy changes, systemic illness other than type 2 diabetes mellitus. The results showed capillary perfusion percentage and flux index among study groups. It was reduced in glaucoma with and without diabetes groups as compared to the controls with and without diabetes group. It was maximally reduced in the glaucoma with diabetes group. As the RNFL decreased, the perfusion percentage and the flux index was also seen as decreased in cases glaucoma with and without diabetes group. The vessel density in the foveal avascular zone was maximally reduced in the glaucoma with and without diabetes groups as compared to the control groups. The foveal avascular zone area parameters among study groups did not show any significant reduction in the control groups as compared to the cases. The peripapillary perfusion percentage, flux index, foveal avascular zone area, and foveal vessel density showed reduction in the glaucoma with and without diabetes groups and controls with diabetes groups. There was a positive correlation seen between the RNFL thickness and OCTA parameters, especially in the superior and inferior quadrants. The glaucoma with diabetes group was the maximum area of interest. When a comparison was done between glaucoma with and without diabetes groups, there were no statistically significant differences observed in terms of peripapillary perfusion, flux index, and vessel density at fovea. The strength of our study was it is a novel hypothesis to establish relation between microvascular changes in glaucoma and diabetes. It can provide direction to future research to find an association between glaucoma and diabetes. We had few limitations, such as OCTA parameters were not correlated with the visual field parameters. The duration of diabetes and the severity was not correlated with the OCTA parameters. Sample size in each group was 32 and was relatively smaller. Further longitudinal studies with larger sample size are required to get more insights. The perfused capillary density in the peripapillary region and vessel density in the foveal avascular zone area was significantly reduced in glaucoma patients with diabetes as compared to age-matched controls. Diabetes-induced peripapillary vessel changes have no additional role in augmenting optic nerve head damage in glaucomatous eyes. Thank you.
Question, did you have any exclusion criteria depending on the refractive error?
Yes, sir, the refractive error as such, no, but the best corrected visual acuity should have been
because
6 by 12.
OCT measurements in high myopes.
No, sir, that was not taken into account.
There can be a source of error.
Yes,
so
sir.
that is one
Okay,
point.
sir. Okay, sir.
And image quality.
Yes, sir. Image quality, only the scan signal strength of more than 7 by 10 was only taken into account. Thank you.
Next, Dr. Prerna. Dr. Rohit Kumar Gupta. Any information about Prerna, whether she's coming or back absent? Great. Okay.
Good morning, one and all. I'll be presenting on cognitive function assessment in glaucoma patients. Glaucoma is defined as a disturbances in the structural or functional integrity of the optic nerve that can usually be arrested or diminished by adequate lowering of IOP. Glaucoma and dementia, that is Alzheimer's type dementia, becomes more severe with advanced age, and they occur more frequently in women than in men. Common genetic risk factors have been reported in Alzheimer's and glaucoma, and similar pathological changes in the optic nerve of glaucoma patients and the brains of the patients with Alzheimer's have been demonstrated. At the molecular level, caspase activation was shown at the rat study of chronic ocular hypertension to induce the abnormal amyloid precursor protein formation, which is the key event in the pathogenesis of Alzheimer's disease. Both Alzheimer's and glaucoma demonstrated early structural changes in the visual cortex and lateral geniculate nucleus affecting magnocellular visual processing. Owing to the common etiopathogenesis of glaucoma and cognitive impairment, it's likely that patients with glaucoma may develop mild cognitive impairment in due course of time. It's also possible that patients with poor cognition will perform poorly the visual field testing, which can give poor follow-up results, improper staging of the disease severity, and poor drug compliance. The clock drawing test is used for screening cognitive impairment and dementia and as a measure of spatial dysfunction and neglect. In the current study, we intend to study the cognitive behavior of the glaucoma patients using a simple test and determining its effect on the reliability of the visual field test. Coming to the materials and methods of a prospective cross-sectional study with 100 cases of glaucoma with no previous history of dementia were recruited in my study. Inclusion criteria were more than 50 with best correction to 0.6 logMAR units. And exclusion criteria are macular degenerations, media opacities, dementia, and other neurological diseases. All patients underwent complete ophthalmological examinations with BCVA, IOP, GAT, and fundus examination, and visual field was obtained using Humphrey Field Analyzer 2 with 30-2 CETA standard program. Glaucoma severity was graded using the Hadab Parish Anderson glaucoma grading scale, and a cutoff was of 15% of false positive and 20% of false negative was considered to identify the unreliable test reports as per recent manufacturer recommendation. Cognitive function assessment was done using a black color pre-drawn circle of 10 centimeter diameter on a white A4 sheet was given to the patients, and they were asked to write the numbers of the clock hours and then set the time showing 10 minutes past 11 o'clock. The time that is 11:10 was chosen because it included both the visual fields and it also had a scope to include the patient who had a tendency to be pulled while setting this time. Patients were allowed to self-correct, no clues were given, and there was no time limit to perform the test. The test was evaluated using two different scoring methods, that is Freud and Rakusa's system. In Freud scoring system, the optimal cutoff was less than or equal to 4, and in the Rakusa scoring system, the optimal cutoff was less than or equal to 3. Coming to my results, a total of 100 glaucoma patients were included in the study, of which 44.6% of patients were in the early glaucoma stage, 35.2% in the moderate stage, and 20.2% in the severe glaucoma stage. At the time of examination, 69.7% of the eyes had reliable visual fields. The mean CDT score of the study population was 1.79 plus minus 1.2 by the Freud scoring and 3.48 plus minus 1 by the Rakusa scoring system. 21.7% patients scored 4 and less on the Freud, and 35.2% of the patients scored 3 and below on the Rakusas, indicating CI in some of the study population. It was found that patients above 63 years of age had statistically significant cognitive impairment compared to younger patients. And meanwhile, patients with cognitive impairment tends to produce more unreliable visual field tests than patients without cognitive impairment. My table 3 shows the mean distribution of visual field reliability and global indices between the groups with and without cognitive impairment. And patients with cognitive impairment have a higher percentage of false negative and false positive errors and a lower visual field impairment than the other groups. It was found that higher CDT scores were associated with lower false negative, false positive, and fixation losses errors, reduced glaucoma severity, and better visual field impairment. There was a weak negative correlation between the reliability indices and CDT, which was more so with the Rakusa scoring system than in comparison to the Freud scoring. And in the table 4 shows the result of a Spearman correlation analysis between CDT and the other parameters. Coming to a discussion part, in my study, we found that glaucoma patients aged 63 and more had 4.2 times higher risk of having cognitive impairment compared to younger age. And in our study, lower limit of the patient age inclusion was reduced to 50 when compared to the previous study, and found to be that 21.7% of the glaucoma patient using Freud scoring and 35.2% using the Rakusa system were scored lower than the cutoff values. This significant increase in incidence could be explained by the age inclusion criteria, which we used, and hence suggesting that cognitive function screening must be started at an earlier stage so that disease can be caught at a premature stage itself. In this study, patients with cognitive impairment had higher false negative response regardless of the glaucoma severity, and which clearly indicates that patients' cognition and memory influences the test results. And these variable findings could be due to different study designs and use of different cognitive assessment. Concluding, the low CDT results were seen in glaucoma patients according to the two different scoring systems, and cognitive and neuropsychiatric problems could have been an impact on the patient's performance while performing visual field and hindering the appropriate diagnosis and treatment. Hence, all glaucoma patients must be screened using the simple and quick cognitive function assessment test, which aids in early diagnosis and help in catching the neurodegenerative disease in early stage. Thank you.
I'll just give you one of the presentation slides should be not the copy paste from the Word, from your thesis or whatever. It should be point wise. So when the people sees, it is presentable and they would see it. If there's a word sentence, then the people lose interest in seeing the slides. Okay, so it will be just point wise, and then you have to practice to speak and not just read from the slide. Okay, that will be much better in future, just when you make the slides. Okay, we just continue. Okay.
Next speaker.
Okay, fine. Dr. Priyanka Shyam. Yes, I think one. Dr. Prerna Gar was absent. Is she present? No, Dr. Deepak has come. Yeah, please start.
Good morning,
You two more
respected,
to go.
respected sirs and madams. As you all know, glaucoma drainage devices have attained popularity in the treatment of refractory glaucomas. The most commonly used glaucoma drainage device include the Ahmed glaucoma valve, the Borwell glaucoma implant, and the more recently introduced Oralab aqueous drainage implant tube, or the RD. RD is a newer non-valve glaucoma drainage device which is derived from the Borwell prototype. Its insertion in the anterior chamber is associated with various complications like postoperative hypotony, excessive capsular fibrosis, tube erosion and plate migration, strabismus, and rarely endophthalmitis. However, the most significant and the long-term complication associated with its use is corneal endothelial damage. Hence, accurate placement of the tube away from the cornea is essential. Various studies have shown that RD placement in sulcus was found to be a safe and effective procedure, offering adequate IUP reduction and reduced endothelial cell loss. The commonly employed technique for sulcus placement of GDD tube involves a relatively blind procedure of entry about 2.5 millimeters away from the limbus directed towards the sulcus with prior insertion of viscoelastic. However, they are associated with various complications like bleeding in the anterior chamber, trauma to the iris, ciliary body and zonules, IOL displacement, and inaccurate entry behind the IOL. So the aim of our study was to evaluate the early outcomes of a modified needle-guided ab interno method of RD tube insertion into the ciliary sulcus. It was a retrospective case series which was planned from July 2019 to June 2021 with a minimum follow-up period of 6 months. A single surgeon performed the procedure at our center. Patients with uncontrolled IUP after maximally tolerated medical treatment, all patients with pseudophakia are those who underwent combined cataract extraction and IOL placement at the time of RD implantation, and patients with secondary glaucomas such as eye syndrome, NVG, and post-retinal detachment surgery were also included. The parameters recorded were name, age, gender, glaucoma diagnosis, and lens status. Visual acuity, IUP, number of AGM were recorded both preoperatively and postoperatively. Intraoperative and postoperative complications were also recorded. Coming to the surgical technique, a fornix-based conjunctival peritomy is done and the tenons is dissected up to the equator. Superior rectus and lateral rectus muscle bellies were isolated. The RD tube is primed using balanced salt solution, and the lateral expansions of the RD plate were placed beneath the muscle bellies of the superior rectus and the lateral rectus muscle, and it was anchored to the sclera about 10 millimeters from the limbus using nylon sutures through the fixation holes. phaco was done in the normal manner and IOL was placed. 2 occlusion sutures were placed at the tube plate junction using 260 vicryl sutures, and the occlusion was confirmed by passing balanced salt solution. A partial thickness rectangular scleral flap was raised. RD tube is cut with a bevel-up fashion to have an intraocular segment of 4 millimeters. A 21 gauge vein needle was introduced from the opposite limbus through the sulcus so that it exits out of this bed of the scleral flap about 2.5 millimeter from the limbus. Now the RD tube is snugly fit into the hollow of the bevel of the needle, and it is slowly withdrawn along its direction of insertion so that finally the tube is placed in the sulcus. Now the scleral flap is closed using 80 vicryl sutures, and finally the conjunctiva is also closed using 80 vicryl sutures to attain watertight closure. Coming to the results, 14 eyes of 14 patients were included in the study with a mean age of 61 years. The male is to female ratio was 11:3. So out of the 14 eyes, 11 eyes had secondary glaucomas and 3 eyes had primary glaucomas. 50% of eyes underwent primary RD implantation in sulcus, remaining 50% underwent phaco plus RD implantation. This table shows a comparison of preoperative IOP, AGM and visual acuity with postoperative values. Here you can see a significant reduction of IOP from preoperative value of 33.57 to 10.21 at the end of 6 months, and AGM also shows a significant decrease from 2.93 to 0.43 at the end of 6 months. However, there was no improvement in visual acuity at the end of 6 months. There were no intraoperative complications. However, postoperatively, 2 patients had 360 degrees of choroidal detachment at 1 month follow-up. Although patient 9 subsided with conservative management, patient 4 needed anterior chamber reformation with pass release and tube repositioning in view of postoperative shallow chamber. Various studies have shown comparable outcomes between sulcus placement and anterior chamber placement of the tube with higher IOP reduction ratio in the sulcus group. A study by Islami et al. Has shown the conventional method of Ahmed glaucoma valve implantation through the ciliary sulcus using a 23 gauge needle. Another study by Tello et al. Has shown conventional method of Borwell tube implantation in the ciliary sulcus with a 23 gauge needle. The advantages of our ab interno sulcus insertion was the accuracy of tube placement in the sulcus in a controlled fashion by withdrawal of the needle, and the ease of tube insertion helps shortening the learning curve among the training surgeons. However, the complication associated with our technique was mainly due to the large needle size of the 21 gauge needle, which required a generous fill of the anterior chamber and sulcus with a highly cohesive viscoelastic. In our case series, there were no patients with hyphema or significant postoperative inflammation, suggesting minimal damage to the angle structures and limited contact of tube to the iris pigment epithelium with this technique. There was significant decrease in IOP and number of AGM was noted. The occurrence of choroidal detachment in 2 patients with the need for reoperation in 1 could be attributed to the angle closure glaucoma rather than the peritubal leakage. Further studies comparing both methods of tube insertion would be helpful in ascertaining the same. Limitations of our study was mainly due to retrospective nature, small sample size, limited follow-up period, lack of corneal endothelial count prior to the procedure. To conclude, the novel technique of sulcus placement of RD tube is a precise and simple method of tube insertion. It's a safe alternative to the existing procedures, limiting multiple blind entries and thereby limiting damage to adjacent angle structures. Thank you. No, sir. No, ma'am. Actually, the 21 gauge vein needle is entering out of the scleral blood partially only. So there is no peritubal leakage. It's not completely entering out of the scleral blood. Thank you. Opposite limbus. Oh, it was a self-sealing incision. 21 gauge vein needle. Through the, it's a clear corneal incision through the limbus. It's possible. Clear corneal through the limbus. It can be done.
Just hydrated.
Intraocular segment was 4 mm. 4 mm. The entry was 2.5 2.5 millimeters from the limbus. 2 and 2, 4.
So sufficient enough to be in ICU. Yes. Thank you very much. Now, the next presenter.
Dr. Nilesh Kumar. Is changing laptop allowed? Here we don't allow. It's time, everybody's time. Dr. Anu is here. Dr. Anu, is she here? No. Dr. Prerna? Sayaka. Next.
So, shall I start, sir?
Yeah, please, please.
Thank you. Good morning to all the judges and everyone in the audience. I would like to thank our scientific committee for providing me this opportunity. I am Dr. Nilesh Kumar, and I am here to present my work, Utility of Smartphone-Based Gonio Imaging to Counsel Angle Closer Patients. My co-authors are Dr. Rita Singh and Dr. Ashish Sharma. These are my financial disclosures. I hold the patent and commercial rights of the device being used in this study, and we have taken utmost precaution that my bias doesn't affect the outcome. So glaucoma, as we all know, is the leading cause of irreversible blindness worldwide, and India has much more higher incidence of angle closer glaucoma compared to the world. The only way to differentiate is open and closed angle is with gonioscopy. But it is not performed in all the patients. In fact, only half of the patients visiting a glaucoma clinic in US get a gonioscopy done at a baseline. And 80% of junior residents are not at all confident doing it, but 25% of the practicing ophthalmologists are not satisfied with the skill they have. So the advances in smartphone photography has revolutionized the ophthalmic imaging and has proved its utility from anterior segment to fundus imaging, and multiple smartphone applications are available for it. A study conducted on the patients having good compliance with glaucoma therapy have emphasized that the main reason behind their adherence to the therapy was a good pre-op counseling at baseline. The role of counseling in glaucoma can never be under-justified. So the research question in our hand was, can we find a reliable, rapid, and frugal method to classify open and closed angles and to utilize it to counsel patients to agree for laser peripheral iridotomy? So we designed a prospective single-center, single-mask counseling study conducted from January 2021 to September 2021. 200 sequential new patients who were never diagnosed for glaucoma underwent gonioscopy and found to have primary closed angles were randomly assigned to the DIX Pro, that is the device being used, and the conventional verbal counseling groups. A single physician did the slit lamp gonioscopy to grade the angle and performed the gonio imaging. A 4-mirror gonio lens was used for both the procedures, and 1+6 smartphone was used for with the DIX Pro to take the gonio image. So this is how the device was set up for use. We placed, so this is how the device was set up for use. We placed the gonio lens in the adapter, which by design itself aligns centrally with the optics of the smartphone holding segment, where the smartphone is snap fit. The normal camera app is used for taking the picture, and we place the gonio lens as in normal fashion under topical anesthesia, and the patient is asked to look straight, and the smartphone segment aligns with the lens adapter, and we click using the camera flash. So the patient is being asked to look straight, and we click using the camera flash. So the image clarity were graded. Grade 1 where all angle landmarks were clear. Grade 2 where some structures were seen, and grade 3 we discarded because no angle structures were ascertained. And we, based on Schaeffer's, grade 2 and below were labeled as closed angles. The physician performing the gonio imaging counseled the patient from both the groups about the angle closure and the need of prophylactic laser PI. Both the groups were shown images of normal angle on the printed chart during the counseling. The number of patients that agreeing for laser PI were documented and were entered into MS Excel and expressed in percentage. 200 patients having angle closure were sequentially counseled after randomly allocating them. 106 were counseled using DIX Pro and 94 using the conventional verbal method. Both the arms were having similar economic strata and educational status. So these are the images obtained, sample images obtained showing open and closed angle using the device. So only 56% of patients agreed for AIOC-PI when counseled verbally, but that increased to 93% when shown that they have a closed angle using the prophylactic laser, for prophylactic laser using DixPro. So these are a few other anomalies that we imaged using DixPro during the study. Gonioscopy is an essential component of glaucoma diagnosis and determines the line of management. The current study provides a cost-effective, frugal, innovative technique to image the anterior chamber angle status. The study also indicates that the smartphone gonio imaging provides a clear, gradable image with sufficient details to allow for the counselor to make the patient understand their anterior chamber angle status. And our group has also evaluated previously the role of image-based counseling in retina. Smartphone imaging also provides for portability and inbuilt teleconsultation, making it a lucrative option in grassroots level patient education. The limitation of the study is use of flash-based diffuse illumination that may induce pupillary constriction, opening up a closed angle. So we are working on that to improve the device to overcome this limitation. To conclude, DixPro is a new frugal innovation that can help in screening the patients for their anterior chamber angle status. Good quality images can be obtained to segregate the patients that might need intervention for closed opposable angle. Thank you so much.
Yeah, a good innovation, but do you really need to counsel the patient? Are you showing the open angle and then their image and document and then explaining to them the closure, or do you expect the patient to listen to your word of mouth? When you say it is closed, the patient, as you said, the percentage rose from 46 to 90.
Yes,
but how did you really counsel the patient? Did you show an open angle
Yes,
image and
yes,
then
sir.
showed his image?
Yes, sir.
Or did you take a class to explain about the angle structures to the patient?
Sir, I just showed, we used open angle pictogram for both the arms, where we showed that you see that this is the brownish thing that you are seeing between the white and the brown. That is the light brown thing is a trabecular measure, that is the open angle, just one line. And then we showed, see this is your image and you are not able to see that brownish thing in your eye. So you have a closed angle and we need to open different pathway through a laser. So
Indentation gonioscopy is not possible using this.
with this, ma'am,
Because it will be already indented.
The flash, so
And they flash. So
Yes, ma'am.
actual in vivo pattern is not clear.
yes, ma'am. We
Lot
have
of bias is
we have
involved.
used the slow motion photography that is available in all the smartphone, and we switch on and switch off the flash, and we see the pupillary constriction in slow motion. So we have images where we have seen the patients having occludable angle when illuminated with flash, it opens up. So
The right way to compare your study would be using this counseling method using a photograph taken by your device,
Yes,
as opposed to any other kind of a thing like a OCT, anterior segment OCT, or a photograph taken by a slit lamp.
yes, sir, sorry to differ, sir, but the main aim of this study was to have a portable thing that we can take to the camps and make the patient
So you
understand
did
at
not
that level.
outline that
Yeah.
in your aims, that this
Yes,
is designed
yes, sir.
for the
Yes.
which
So-
kind, because you are tertiary center, then it has all the facilities.
Yes, sir, this was just the pilot study being done, sir.
So that was not outlined in your.
Sorry,
initial
sorry,
plan.
sir.
That's
It's a
exactly
good
what I
idea,
said.
but
It's a
in
good
your
innovative
first slide you
tool for
say-
documentation, but not for this. There is no end to this. Once you start counseling the patient, showing this image, the patient will demand a post AIOC-PI image also to show and demonstrate that the angle has now opened.
Opened.
So
yes,
there is
yes.
no, it opens a Pandora's box, and you just can't guarantee that to every patient.
How many percent of the images were not good enough to analyze?
So in the study that we did, there was a different study we have published in I. There 80% of the images we have
So
taken have been
20%,
readable. 20%.
20% you could not
we
analyze
could not
because
do,
of the
sir.
poor quality.
80% only
Second,
we
the
could do,
video
sir.
you showed,
Yes, sir.
you had kept the room light on.
Yes, sir.
So that
So
also
that
will
was
have
just
a.
for the videography. So we do it in a closed light, sir, because
but
we had to
then
take
you
a
must
videograph.
mention that you are following the ideal conditions for the
Yes.
gonioscopy. When you show the video with the full room light on,
Yes.
it gives a different impression to the people who are watching the presentation.
Yes.
Okay.
Thank you, sir. Thank you so much, sir.
Dr. Deepak, please. Dr. Anu has come, or
respected judges, my teachers and dear friends. My AIOS number is 12337. I am going to present my study correlation of blood parameter as a novel marker in primary open angle glaucoma. It's not moving. Now it's moving. Yeah. There is no financial disclosure in it. As we all know that glaucoma is a chronic disease, and whatever the damage has been done has never been repaired. Means whatever the damage is there, that damage must correspond to something which is happening because of the damage to nerve fiber layers or something. So our studies plan are based on that previous studies, that previous many authors did their study, that whenever is any damage to ganglionic cell or any neuronal damage, then there must be they have find out that there is some changes in the blood parameters too, and that is the reason behind our study. So whether to find out that these changes has occur in glaucoma or not, that is the point when we have taken this study. And our aim is very simple, to find out what is the relationship between the neutrophil and lymphocyte ratio and platelet to lymphocyte ratio as a serum or a blood marker in patient with primary open angle glaucoma. So this is an hospital-based clinical prospective study done at the Regional Institute of Ophthalmology, BHO. Sample size was 150 and duration was 3 years. And the study was done after taking the proper ethical clearance from the institute. Material method what we have used, again, the inclusion criteria was all the patients who are coming to our OPD and diagnosed to have primary open angle glaucoma, and exclusion criteria for any other diseases which are not the cases of not primary open angle glaucoma, and some other diseases which have neuronal damage like hypertension or whatever the risk factors we have ruled out. All the investigations which are required for the diagnosing of glaucoma has been done, and the blood parameters we did was CBC, absolute platelet count and absolute neutrophil count. Now coming to observation and result. In our study, the females were less in this percentage, means 44%, and male were 55%, and mean age in our study was 49 plus minus 10 years, and mean IOP at the time of diagnosis was 24 plus minus 3 mm of Hg. This is the table showing the group, what is the difference and what are different patients were enrolled in the study. And this is the something which is the important, we find out that this is the normal reference value. When we have something, it is point there, and when we move it in the cases of glaucoma, there is significant difference between this neutrophil and lymphocytic ratio, and same is the when we find out there is significant difference in case of platelet and lymphocyte ratio in cases of normal and in the cases of glaucomatous patient. Now coming to the discussion, as we all know that few studies has been done, but none of the studies when we have taken is published in we have searched the PubMed literature from the Indian side, so we have done it. And the mechanism behind the primary open angle glaucoma we all know is multifactorial, and there is something which have some inflammatory changes that would lead to the damage of nerve fiber layer, and it is believed that whenever there is an IOP change, there will be neurodegenerative conditions, which explains that this lead to higher these platelets and blood markers. So in conclusion, we believe that our study found out that increased IOP is probably because lead to neurodegenerative conditions, and that these degenerative changes reflected in blood and leads to this rise in parameters. Limitation of our study is it is a small sample size. We lack the coordination, and whatever the pro-inflammatory markers of the glaucoma are there, we didn't correlate with these platelet markers. Whether we have, if we have correlated with these blood inflammatory marker too, then it will be a much better study. But that is the suggested for the future study, that if we can correlate all the threes, whatever the established markers of glaucoma along with the clinical and these blood parameters. But still we suggest that in cases of glaucoma patient in a community where things are not there and if there is some family history of glaucoma or something, then these only the simple blood test which is available in each and every corner in the community can give some suspicion that the patient may have glaucoma, or can go for the screening, not for the diagnosis, but at least screening we can go it. These are my references. Thank you.
Thank you for a very innovative study. What I wanted to ask was there any correlation with systemic inflammatory statuses, whether you have...
Sir, in previous, before we taken this study, we find out that there is 4 or 5 studies done. One is done on the this one, BRBO cases with platelet markers, and another one we have taken from the psychiatric patient whenever there is damage, there is association. So nowadays, blood platelet markers is something which is done in most of the cases. But in glaucoma, we didn't find out in 2017 that this can be done in even the primary open angle glaucoma. So we have taken this, that when it can be whatever the result, but we found out that it is showing the positive correlation with.
No, but do we have to exclude patients with, say, tuberculosis?
That's we excluded, sir. I already mentioned in my exclusion criteria that whatever the other causes which leads to the platelet or the blood parameter damage, we have excluded that. Any questions?
Thank you.
Thank you, ma'am. Thank you, sir.
Dr. Prerna? Yes, she has come. No, I think Dr. Anu. So I think this is the last presentation of our session.
Good morning, everyone. So my free paper presentation is on a study which was outcomes of ab interno goniectomy with trabectome in primary and secondary glaucoma from a single center in India. And I am the presenting author. The chief author is Dr. Sunita Dubey. So minimally invasive glaucoma surgery is slowly gaining popularity due to its better safety profile. Trabectome is a handheld device which has been approved by FDA in 2004 for clinical use, and it works by ablating the trabecular meshwork with the bipolar 550 kilohertz electrode and helps to restore the original aqueous outflow pathway. It can be used in patients with open angle glaucoma, either primary or secondary, and can be combined with cataract surgery. It can also be used in congenital glaucoma as an option as a goniotomy, and it is found to be better than goniotomy because it has a theoretical advantage of decreased risk of cicatricial closure of the trabecular cleft. So in this pilot study, we described the efficacy and safety of trabectome surgery over a 1-year period in Indian patients presenting with different types of open angle glaucoma in a single tertiary care center. It was a non-randomized longitudinal retrospective study, and it included patients with OAG who underwent trabectome surgery between the period January 2019 to February 2020. Informed consent and ethical approval was taken. So the inclusion criteria included all patients of all ages, ranging from of open angle glaucoma. It included patients of ocular hypertension, POAG, congenital glaucoma, juvenile glaucoma. Patients with prior history of glaucoma surgery were also included, and those with angle closure glaucoma in whom the posterior trabecular meshwork was visible post YAG-PI were included. Patients with secondary open angle glaucoma like uveitic glaucoma, pigmentary pseudoexfoliation glaucoma were also included. This was the inclusion criteria which was followed. The exclusion criteria was patients with primary or secondary angle closure in whom the angle structures were not visible, and those who were lost to follow-up before 1 year post-surgery. The IOP measured on the last visit prior to the trabectome surgery was taken as the baseline IOP, and a pre-surgery evaluation included the type of glaucoma, details regarding prior eye surgery, the best corrected vision, IOP, corneal status, lens status, the examination of the angle and grading, and the number of anti-glaucoma medications which the patient was on. Patients with significant cataract underwent combined trabectome and phacoemulsification surgery. The outcome measures was a reduction in the intraocular pressure, the reduction in the number of AGM, the success percentages, intra and post-operative complications. And the follow-up was at 1 day, 1 week, 1 month, 3 months, 6 months, and 1 year post-surgery. Absolute success was defined as reduction of IOP of more than equal to 20% from baseline, and IOP less than 21 millimeter mercury with no secondary surgery throughout the follow-up period. And if the eyes require any additional glaucoma surgery, if they develop phthisis or loss of light perception, then it was considered as a failure. The surgical technique was done by a single surgeon. A 1.7 mm near limbal temporal corner incision was made with a keratome. The gonio lens was placed, the Swan-Jacob lens. The trabectome was advanced nasally with irrigation on and inserted through the trabecular meshwork. And ablation was commenced at a power of 0.8 milliwatt and approximately 120 to 140 degree of the trabecular meshwork, 60 to 80 degrees on either side was ablated. The ablated tissue was aspirated via the irrigation aspiration lumen of the handpiece. And patients who also had cataract, they underwent trabectome first and then phacoemulsification through the same port. The statistical analysis was done by a paired t-test, independent t-test, and ANOVA. The success of the procedure was analyzed using Kaplan-Meier analysis, and p less than equal to 0.05 was taken as statistically significant. So coming to the results, the study cohort included 58 eyes of 53 patients. The mean age was 48 years, and it was ranging from 6 months to 81 years. The 26 eyes underwent combined surgery, phaco plus trabectome, and the rest 32 eyes underwent only trabectome surgery. The cohort also included 10 eyes of children less than 18 years with the diagnosis of either juvenile or congenital or secondary glaucoma. This is the demographic table. So in this we can see the POAG, there were 28 patients with POAG, 8 patients with GOAG, and 6 patients with congenital glaucoma. Also secondary glaucoma was included, open angle. So pigmentary glaucoma, there were 4 patients, pseudoexfoliative 1, and uveitic glaucoma, there were 2 patients. Out of the 6 patients had undergone a prior trabeculectomy, which had failed, and 52 patients had not undergone any other surgery. So the baseline IOP in patients who had only trabectome was 24.4 millimeter mercury, and in those who had a combined surgery, it was 16.6 millimeter mercury, the mean IOP. Coming to the intraoperative findings, so intraoperatively, significant blood reflux was observed in 46.5% of the eyes, and out of these, only one eye required tamponade with viscoelastic agent. Remaining were managed by anterior chamber wash without any additional maneuvers. The post-operative outcomes, the IOP changes from baseline post-surgery. So we can see that there was a decrease from 24.4 millimeter mercury to 14.6 in those who underwent trabectome alone, and in combined surgery, it decreased from 16.6 to 13.4. So there was around a 40% decrease in both the groups. And there was also a decrease in AGM from 2.2 at baseline to 1.5 at 6 months and 1 year post-surgery. The success rate on an average was 76%. It was higher, 88% in those who underwent trabectome plus phaco, and slightly lower, 67% in those who underwent only trabectome. And 4 eyes out of the 58 eyes required additional glaucoma surgery and were considered as failures. No eye developed further decrease in vision or loss of perception of light. So from this study, we can conclude that trabectome, which is an ab interno minimally invasive technique, can be used in Indian eyes presenting with different types of OAG with good clinical outcomes. And it can also be used safely and successfully in the pediatric cases presenting with congenital and juvenile glaucoma. However, further studies with a longer follow-up are needed to assess the true efficacy and safety of this procedure. Thank you.
So did you mention the visual field defect, that
So
the stage of glaucoma?
So around 50% of the patients had cataract. So visual field was not taken as a criteria to diagnose.
No.
It was on the basis of.
The success of result depends upon the amount of damage patient has.
Yes, sir.
And when you say IOP less than 21 is success, if the patient has moderate to advanced glaucoma, that is not good enough. So if you look the WGA guideline, the consensus number 11, we say that what you should look into the success of surgical, the criteria, they've defined very well, and less than 21 is not important criteria anymore. Because if you have taken advanced glaucoma, then 21 is not good enough to start with. So it is very important. I don't think all patients would have mature cataract that they could not do field. If there's a patient has early cataract, they would able to do the field, and you have to include in your inclusion criteria and for result analysis also. Okay? Because 1 year, to start with 1 year data itself is not important. The glaucoma is a long-term disease. So if you don't have all this data, then the using the data is anyway not important. So you have to have more data.
Progression was not seen.
No progression. I'm not worried about progression. 1 year there is hardly any progression. So I'm more interested in looking at what kind of glaucoma you had, and for that group of patients, this percentage of IOP reduction is adequate or not. Okay.
Yes,
I'm
sir.
more interested that you are not providing the data to me.
Yes, sir. So actually, number of the AGMs were added if the IOP was less than 21 but not reaching the target IOP, then AGMs were added.
But you
that
have
was
to
not taken as
provide
a
the
failure
data
in the study.
to the people.
Yes.
Okay, you have decided that you will add, but other people who want to see whether this procedure can be used in their practice, you have to provide the data. You cannot say I have done this, and I'm right. It's not like that. So if you have not provided data, then the other people would not able to
so the only
utilize
thing-
the study. So I do not argue.
No,
I am
I'm
just
not
telling
arguing,
you
sir.
that this should be done. Okay.
Yes, I'm not arguing, sir.
So, final
Have you done the
call.
gonioscopy afterwards?
Yes, ma'am. Gonioscopy was done.
What
and-
was the finding? There's a lot of
She's
scar
not
and a
there.
membrane in the angle when you do the trabectome.
Yes,
It's
ma'am,
a
sorry.
shrinkage of intercanalicular openings also.
Actually, in one video also, in the surgical video, we saw that the collector channels had opened. There was blanching of the collector channels.
On table, it's a post-op I am talking.
Post-operative, we could see a
After
cyclodialysis
6
cleft.
months.
We could see a cleft. Even 2 years post-op, once I've seen a cyclodialysis cleft was visible in the nasal angle.
It's
Sorry,
not,
I'm not sorry. Not cyclodialysis.
It's not
cleft.
Cyclodialysis cleft, it is
cyclodialysis.
different thing.
It's a
That would
different
go into
thing.
complication.
This is the angle morphology which has altered because of the fibroblastic activity.
Sorry, it's just like cleft was seen, yeah. In the nasal angle, it could be seen.
Okay, thank you everyone.
So Dr. Anu is absent. Yeah.